Well, hello everyone, this is Dr. Galaxy and I welcome you to the second part of the clinical case of our last video, and this is why is this patient coughing part 2. We decided to make two videos out of this clinical case because the patient and the history and the findings we had in this patient were so complex that it would have exceeded the duration of one video. So this video now concerns about the secondary findings, the pathological findings we did not refer to in the first video, and I hope you liked the first video and like this one too. Let's get right to it. Okay, let's go. Just to refresh your memory, the first part was about a structure on the ventricular lead of a 2-lead pacemaker system the patient had because of total AV block after a Ross operation, and this structure seen here in the tissue Doppler imaging shows a bacterial vegetation on the ventricular lead of the patient, a lead infection, and that was caused by Staphylococcus aureus after an elective replacement of the battery of the pacemaker, and through this opening of the pocket the bacteria came into the pocket and into the leads and caused this horrible infection with a high risk and danger of the patient. And some parts of this vegetation got loose and caused a pulmonary embolism. That was why the patient presented to us and to the emergency department. This is the structure again on the ventricular lead and the transesophageal echo on the atrial side of the ventricular lead. Here you see this floating bacterial vegetation in the right atrium. Well, but there were some more findings in this patient that I wanted to show you. And first of all, when we perform the transesophageal echocardiography, we also take a look at the interatrial septum. And from this point of view, the interatrial septum looks fine and competent. There's no hole we could see here for patent foramen ovale or ASD or something like this. And this is not the best view for the IAS, so you would do some color Doppler, different angles, maybe contrast or something like this to have a closer look. This was not the focus in this examination of the heart, because we focused on the lead infection here to differentiate between thrombus and bacterial vegetation infection. But you always have also a look on the IAS. And if you zoom this a little bit more, then you can already appreciate that there is a jet from the left atrium into the right atrium. So we have a left-right shunt over the interatrial septum, and this is called patent foramen ovale. And here you see it in the native B mode, also very clear. Okay. Patent foramen ovale is one of the secondary findings. Let's move on to the next one. I told you in the first video that this structure down here, directly underneath the posterior mitral valve leaflet, looks anyhow strange. Is it a PML sclerosis or something else? We know the patient had a lead infection. Could this be an abscedation maybe? Or what do you think this is? In the apical 4-chamber view, we see this structure again, and also here it's looking very prominent, and normally you don't have such a prominent structure seen in the apical 4-chamber view here, right? So what do I think is this structure now here in zoom to see? And another view in the transesophageal echo. Seems like there is a little wall here. Like this is a round-shaped structure. What could it be? Is it A, an abscess, abscedation, B, a coronary sinus, C, pulmonary vein, or D, PML sclerosis, or E, it's just the left circumflex, left coronary artery, the ramus circumflexus? What do you think? Okay, I'll give you the answer. It's the coronary sinus, and most of you will have known that, but I just wanted to show. If you put the color Doppler inside, then we see this structure indeed is a closed structure, closed or separated from the left atrium. Here's a wall, and there's color inside. There is blood flow inside. So abscedation would not have color inside, flow inside, only if it's already ruptured. And but then you would not see such an intact wall here. Then the wall has somewhere a hole inside, and this is absolutely intact. So this here is the coronary sinus, but doesn't it look too prominent? Normally we don't have this structure such big in the left atrium, don't we? Very prominent here. So why does the coronary venous sinus look like this? Well, sometimes you have an anomaly, and that can be that the right superior vena cava and the left superior vena cava are not connecting while the evolution of the child. And normally the left superior vena cava is connecting with the right superior vena cava, forming the superior vena cava communis, if you will, over the anonyma, and going then into the right atrium. Sometimes this connection does not happen, and the left superior vena cava is not going into the communis, but going separately into the right atrium. There can be a lot of different anatomies and anomalies that where the left superior vena cava is connecting to the right atrium, sometimes directly into the atrium, but very often it first connects to the coronary venous sinus, coronary sinus. And if you have this, we speak of a persistent left superior vena cava, and if it first connects to the coronary sinus, then the blood of parts of the upper extremity and the left part of the upper extremity are connecting to the coronary sinus, not only getting blood from the heart. And that is much more blood the coronary venous sinus has to take into the right atrium, and the coronary sinus is dilated. And if you have this condition, it's very difficult to place or implant a pacemaker from the left side, where most of us implant the pacemaker from the left vena cava or the left subclavian vein over the anonyma and vena cava communis into the right atrium and the right ventricle. But if you have this anomaly, it's very hard to derogate the leads through this persistent left vena cava superior and over the coronary sinus and so on. There are different difficult angles you have to take with the leads to place them into the right atrial appendage and the right ventricular apex or septum. So if our suspicion is right, the colleagues who implanted the pacemaker would have chosen the right side for implantation and not the left, or they tried the left side and then switched because they had problems implanting the leads and switched to the right side. So where is the pacemaker implanted? And indeed, if we take as reference the chest x-ray picture from the emergency department where the patient presented, then we see that the colleagues indeed put the pacemaker on the right side. What support our hypothesis? And what can we do to further support our theory and to make the diagnosis of a persistent left vena cava superior? We had the chest x-ray that was performed when the patient initially presented to the emergency department, and there we performed the chest x-ray to exclude, or in this case confirm, the pulmonary embolism. And with this examination we had contrast given by a venous line that laid on the left cubital vein of the patient, and he lies on the back and his arms over his head, right arm and left arm. The contrast will come from here, from the cubital vein into the subclavian vein, and then have a look where the next course is taking. The subclavian vein is now already filled, and now there it goes down. It goes down, not over the aneurysma to the other side and connecting to the right subclavian vena cava, but it goes down as a persisting left vena cava superior, and then over the coronary sinus into the right atrium. So this is the confirmation of our hypothesis of a persistent left vena cava superior. I copied some pictures for you. So over the left arm and the venous line, the contrast comes here and fills the left vena subclavia, and then goes down into the persistent left vena cava superior, not going crossing the thorax and connecting to the right vena cava superior, but going down here, connecting to the coronary sinus and into the right atrium, what confirms our hypothesis and our theory. Again in moved motion, and there it's going down and into the right atrium. Wonderful. Okay, so this is another pathological finding we had in this patient. Persistent left vena cava superior. And is it possible in this situation to implant pacemakers from the left? Well, in this case, the colleagues decided not to implant from the left side, where we normally would implant the pacemaker, and the pacemaker leads the locotypical. But is it possible to do so? Yes, it is. Some colleagues are performing this. I took these pictures from the web and found some colleagues who implant also from the left side over the left vena subclavia into the persistent left vena cava superior, and then making a move through the coronary sinus, a loop into the right atrium, into the right atrial appendage, over the tricuspid valve, here into the right ventricular apex. So it is possible to get the leads in the right place, in the right atrial appendage and the right ventricular apex. And even with the ICD leads, you can perform this procedure over the persistent left vena cava superior, then coronary sinus into the right atrium, then over the tricuspid valve, and then into the right ventricle. So if you see this structure, it can be a mitral sclerosis, of course, but it can also be the coronary sinus. And you will see this very often, but not as prominent as in this case. And if you have such a prominent coronary venous sinus, just think about the diagnosis of an anomaly and the persistent left vena cava superior. And especially if you want to perform a pacemaker implantation, just be prepared for complications if you do it from the left side, and have some different approaches and exit strategies. And here again, this dilated coronary sinus in the apical 4-chamber view. Well, thank you for your attention. That was the part 2 of the why is this patient coughing clinical case, and I just wanted to show you all these secondary findings because it's rare that we have such a complex patient with so many pathological findings, and I wanted to share all these things with you. So if you liked it, give us your thumbs up, maybe subscribe to the channel, give us your thoughts and comments down in the comment section, and stay tuned for our next videos. That's it for now. Yours Dr. Galaxy. Bye bye.